So, a very warm welcome to everyone for joining us here this evening. So, welcome to tonight's webinar on the role of the GP in improving cancer outcomes and achieving equity in cancer care, which has been hosted by the Caring Futures Institute, Flinders University, in partnership with Cancer Australia and the Primary Care Collaborative Clinical Trials Group PC4. It is fantastic to have your company here with us this evening. So again, a very, very warm welcome and thank you for joining us. My name is Catherine Patterson. I'm a Professor of Cancer Nursing and the co-lead of our Cancer Survivorship Programme at Flinders University and also in Central Adelaide Local Health Network. And I'm delighted to be your chair this evening. So if we could advance to the next slide. Wonderful, thank you. So I would like to start by acknowledging the traditional owners and custodians of the lands and waters on which we are dialing in from across Australia, and I would like to honour elders past, present and emerging. Thank you. So just before we kick off for our webinar this evening, just a couple of housekeeping aspects, if that's okay, before we get underway. So your microphones and your cameras will be muted for this webinar and the chat function is not available. But please do, however, use the Q&A function to post a question to the speakers, and we will have a Q&A session later on in the session of the webinar this evening. This webinar will be recorded and you will receive an email notification when the recording is available online for you. If you are a member of the RCCGP or the ACRRM member, then please do provide us with your number, and your CPD hours will be automatically logged on the webinar. Please do allow 6 weeks for your hours to appear on your record, and if you didn't provide us with your CPD number, that's absolutely no problem at all. Please just drop an email to us on the website address that you see here on the slide, and we will be able to provide that with you and for you with your full name. So again, thank you so much for joining us. So just moving on to our next slide, I have the great honour and privilege to introduce so many wonderful national and international leaders here with us this evening. So tonight we have 3 amazing, great presentations from Professor Vivian Milch, Associate Professor Kylie Vong, and Associate Professor Carolyn E. We will also be followed by a panel discussion with Associate Professor Joel Ree, Professor Michael Jefford and Mr. Eric Young. And we will finish with a Q&A session with all panel members with questions from the audience. So as we're going through the presentation, please do pop your Q&A questions into the chat and we'll be able to address them towards the end. So without further ado, it is my absolute honour to hand over to Professor Vivian Milch for a presentation kicking us off this evening. So Vivian is a Medical Director at Cancer Australia. In this role, she provides strategic clinical policy input to Cancer Australia's work to minimise the impact of cancer, address disparities and improve health outcomes for people affected by cancer in Australia. Professor Milch is the Medical Advisor to the Commonwealth Department of Health and Aged Care on the Cancer Screening Policy and also the Chair of the Clinical Advisory Group for the Breast Screen Australia and the Expert Advisory Committee for the new National Lung Cancer Screening Programme. Vivian also holds professorial appointments at the Caring Futures Institute at Flinders University and also the School of Medicine at the University of Notre Dame. Prior to joining Cancer Australia, Professor Milch was also a general practitioner and led clinical research at the Garvan Institute of Medical Research, Sydney, and holds a Master's in Health Policy from the University of Sydney. So without further ado, it's my great honour and privilege to hand you over to Vivian.
Thank you so much, Catherine. Thank you for that warm introduction. And thank you all for joining us this evening. We really appreciate you giving up your time to come to this very important discussion about the role of the GP across the cancer care continuum. Before I begin, I'd just like to acknowledge the traditional owners of the lands that I'm joining you from. It's the Gadigal people of the Eora Nation, and I'd like to pay my respects to elders past and present, and to acknowledge any Aboriginal and Torres Strait Islander people who might be joining this webinar. So just moving to the first slide, just to the next slide, thank you. The Australian Cancer Plan, you may or may not have heard about, was launched in November of last year. It's Australia's first national cancer plan, and it's been in development for the last couple of years, and it's really a pleasure to actually speak to this very, very important audience of GPs and people working in primary care about the Australian Cancer Plan. I know that when I first started in general practice, the role of the GP in cancer care was actually very limited. It was about, I guess, involved a little bit in screening, diagnosis, and then the person just went off to specialist care and really had very little, the GP had very little to do with cancer care. What we really noted and really highlighted in the Australian Cancer Plan is how important the GP is right across the cancer care continuum. And I will talk a little bit about that together with the other people who are joining me on the panel tonight. So just let me start by telling you a little bit about the Australian Cancer Plan. And really, I would encourage all of you to go online and have a play with it. It is actually an online plan. It's not a book. It's interactive. And it is a very interesting read that you can sort of dip in and out of, but it does really talk about lots of different aspects of cancer care. So for starters, it's about all cancers. It's not actually about any particular tumour type. And it concentrates on addressing the disparity of experience and outcome that we have in Australia. So we know that for many Australians, we have the world's best cancer outcomes in across all cancers, actually. And for many Australians, you couldn't do better than the cancer care that we have. But we also know that there's disparities across various population groups, particularly for Aboriginal and Torres Strait Islander people. And we make a very strong focus on the outcomes of Indigenous people in Australia in the cancer plan. But it actually concentrates on other priority population groups, and I will talk about those in a minute. So we developed it with a very comprehensive stakeholder engagement strategy. We talked to so many different people, people affected by cancer, people working in cancer of all sorts of different disciplines, health sector, health researchers, managers, all sorts of people, in order to put together what we think is actually representative of what people really want to have and what need to make cancer care better in Australia over time. So right at the centre are the optimal care pathways, which are like national standards to help consumers navigate their journey across the cancer care continuum and to know what to expect in cancer care. It focuses on priority population groups, and it has very clear 2 and 5 year goals and actions that we are going to have to address and meet in order to get to our 10-year ambitions. So just moving to the next slide, this is the conceptual framework of the Australian Cancer Plan. It starts on the left-hand side with lots of various cancer plans and community plans, health plans and tumour initiatives that just slot into the plan. It then has 6 main strategic objectives. Actually, just going back, if you could, just to the previous slide, that's it. If you look down, you see that little circle at the top. That's the beginning of the 6 strategic objectives that there are in the plan that start with cancer prevention and early detection. And that's really where I'm going to focus a little bit after the next couple of slides. The enhanced consumer experience, looking at world-class cancer health systems so that we can provide optimal care. Keeping on that previous slide, that would be great. Thank you. And if you just go back to the previous slide, that would be excellent. And then I will work through these strategic objectives, and then those priority population groups on the right side, you'll see all the various groups of people that we are thinking about and concentrating on in the Australian Cancer Plan. Now we'll move to the next slide. I won't concentrate much on this slide. It is one that is just an overall picture of the Australian Cancer Plan. It just puts everything that we say together on one page, but it highlights the 46 actions that you can see in the Australian Cancer Plan. So now we'll move to the next slide, and I'll just run through some of the aspects of the Australian Cancer Plan where we are really focusing on the GP. That's the run. So we're going to start with cancer prevention and early detection. This is a place where GPs really can make a huge difference to outcomes. One of the things that was highlighted in our consultation for the Australian Cancer Plan was how important it is that we note that we acknowledge and we eliminate racism in our system. We heard from Aboriginal and Torres Strait Islander people how racism was just something that they experienced on a daily basis in the cancer system and in the health system, and that we really needed to acknowledge and eliminate racism. We also need to proactively reduce cancer risk, and there's a real role for GPs in prevention, and Kylie's going to do a bit more in a discussion about prevention in one of the next talks. We know that personalised evidence-based cancer prevention and early detection strategies are critical. And there are actions in the Australian Cancer Plan that really refer to the work that GPs can do in looking at risk factors for cancer, in increasing screening participation, in learning and recognising cancer symptoms in order to enable early detection, and in personalising prevention. So just moving now to the next slide, you'll see then that what we have in our toolbox for early detection is a number of cancer screening programs. So we're very lucky in Australia to have organised cancer screening programs for cervical cancer, which started in 1991, and we are about to make a statement soon that we'll be able to eliminate cervical cancer based on this very effective screening program and our vaccination program. We also have a very effective Breast Screen Australia program that was launched in 1991 and is now having a review of the Breast Screen Australia program to see if we can really maximise its outcomes. But we're very lucky to have this national, fully funded, free mammographic-based screening program. We also have a national bowel cancer screening program, which has a long way to go in terms of realising its success, mainly if we could increase participation in this very effective, very simple screening program. And Kylie will address those population screening programs in her talk. I'm going to spend the next few slides, though, talking about our new National Lung Cancer Screening Program. We were very excited when in 2023 the Minister for Health announced a National Lung Cancer Screening Program. Now you can see on this slide that the screening program is effectively a 2-yearly screening program for people aged 50 to 60 years who have a history of smoking, who are either current smokers or if they're a former smoker that they quit in the last 10 years, and that overall they have a 30-pack year smoking history. So at the moment, they are the people who are eligible to join the National Lung Cancer Screening Program. And this screening program will start from July of 2025. The reason that we need to screen for lung cancer is that lung cancer is the biggest cancer killer in Australia. It kills 9,000 Australians each year, and it has a particular impact on those Australians in various priority population groups, for Aboriginal and Torres Strait Islander people, for people living in rural and remote areas, for people living in lower socioeconomic areas, for those people living with a mental illness. For many of these groups of people, lung cancer plays a huge role, and we have a big opportunity to find it early and to improve outcomes in lung cancer. So across the bottom there, you can see all the work that we're doing to try and to set this program up. But one of the things that we really know is how important the GP is. So just moving to the next slide, you'll see here, this is what the screening and assessment pathway looks like. And I will actually in the slide after this, but I'm not going to move yet. We're going to talk about what the role of the GP is. So I've just talked about just now who will be eligible for the lung cancer screening program. We are actually at every step of the way going to be thinking about smoking cessation, because we have an opportunity in the lung cancer screening program to do effective primary prevention at the same time as screening. We'll also be thinking about with these people, making sure that we're actually having asymptomatic people in the screening program. And one of the roles of the GP will be to actually assess eligibility, make sure that we're looking at the right age, the right smoking history, and those people who are asymptomatic. And the intervention will be a low-dose CT scan. A low-dose CT scan will be able to be done in the community at private and public radiologists, and those radiologists will be upskilled to report the low-dose CT scan in the same way right across the country. And that's one of the things that we're doing at the moment, is working with the Royal Australian and New Zealand College of Radiologists, so that every report from that low-dose CT scan will look the same. So out of that low-dose CT scan, the LDCT, we will find 5 main categories of people. There'll either be no significant findings, in which case the person will just be re-invited back onto the for another low-dose CT scan in 2 years' time. Or there'll be a number of other categories of nodule risk assessment, either a low malignancy risk, a moderate malignancy risk, a high malignancy risk, or suspected lung cancer. And at each of those pathways, there will be a very definite and clear instruction on whether that person needs to go straight to a specialist linked to a multidisciplinary team, for instance, if they have suspected lung cancer, or if they need another low-dose CT scan in a shorter period of time. And there'll be very structured education, which we're developing with the Royal Australian College of GPs and ACRM for everybody to do, so that we as GPs will all be ready to go from July of next year. So just moving to the next slide, you'll see on this slide opportunities. Moving to the next slide now, you'll see on this next slide opportunities for where the GP can help with lung cancer screening. So you'll see that obviously GPs are very, very important for recruitment. People can come to see you. They can they can refer themselves after seeing an ad, for instance. They might be facilitated in that it might be that they might be going to Quitline or another type of another specialist or another allied health specialist and be referred to see you. Or you might actually go through all your records and find those people who have a smoking history which would make them eligible. There will be a number of different ways that you'll be able to bring people into the program. So after confirming eligibility and doing shared decision making with informed consent, and we are developing all of the documents that you'll need in order to do that, the person will be registered with the National Cancer Screening Register. And I know that Kylie is going to talk about the importance of the National Cancer Screening Register to support GPs in patients participating in screening programs. After the person is then referred to have their CT scan, that will be done by the radiographer and radiologist, and then a report will be sent back to the GP and also to the National Cancer Screening Register. And the GP will be absolutely critical in referring the person on for more investigation and potentially for treatment. One of the other things that we expect to find, though, in this program is that we will see people with incidental findings. Obviously, we're doing CT scans on people who are at high risk of other disease as well, based on smoking history. And those incidental findings will be clearly laid out in the report, and with instructions on further management of those incidental findings. So just now moving to the next slide. So thinking more about other things that the lung cancer, that the Australian Cancer Plan provides. One of the things that we found when we talked to patients, people affected by cancer, is that they talked about the importance of they wanted to find their cancer early to enable better treatments and better outcomes. But they also wanted to be cared for and have a good experience, as good an experience as possible through their care. And one of the things that was really highlighted was that we have care that is tailored to that individual. And we've highlighted here on the right side of this slide a number of different ways that GPs can be involved in ensuring that that people with cancer are actually having the best care that they can have. GPs are a very, very important part of the multidisciplinary team who are looking after the patient. And we're very lucky to be joined by Michael Jefford, who will talk a little bit more later on about how the GP can be involved in the survivorship care of a person after they've finished their active treatment and through their survivorship journey. Tailored information and providing the right information to the person at the right time is critical to enable people to feel empowered in their journey. So now moving to the next slide, you'll find that we've got here an image of the cancer care journey that we hope that people will be able to go on, where they'll be supported by an integrated navigation system. And that's one of the things that we're setting up in a online and together with a nursing workforce to support people through their screening, investigations for cancer, diagnosis, treatment, survivorship care, end-of-life care, if that is required, and palliative care. So we have a system that's being designed to better support people in their navigation journey across the cancer continuum. Now, I'm just going to move now to my next slide. It's the last slide that I have before we'll move on to the other speakers. A very critical aspect of the Australian Cancer Plan is achieving equity in cancer outcomes for Aboriginal and Torres Strait Islander people. So if we just go to that next slide now, you'll find that we're thinking in how to do that right across the system to try and enable to have a cancer control system that seeks to eliminate racism, that proactively reduces cancer risk and supports prevention and supports collaborative partnerships across the cancer care continuum to enable culturally safe, trauma-aware, healing-informed care for Aboriginal and Torres Strait Islander people to improve outcomes. So that's it from me. I'm very happy to answer questions later on at the end, and I look forward to the next few speakers before we get to our questions and answers. So it gives me great pleasure to introduce Kylie Vuong. Kylie is an associate professor in primary care. She's an academic lead in general practice at Griffith University. She's also the co-chair of prevention and early detection at PC4. Kylie is a GP with a research interest in prevention and early detection of cancer, and she undertakes collaborative teaching and research to improve patient health outcomes through comprehensive patient-centred care. Kylie's a fellow of the RACGP, and she has an amazing lineup of degrees. She has a BSc in medicine, an MBBS from University of New South Wales, a MIPH from the University of Sydney, and a PhD in cancer epidemiology. And Kylie is now going to speak about the role of the GP in cancer prevention and early detection. Thanks so much, Kylie.
Thank you, Vivian, and thank you to everyone for joining us this evening. I'd like to acknowledge the traditional owners of the land on which we are meeting today. I also like to pay my respect to elders past and present. Next slide, please. Next slide, please.
Sorry, Claire, it's just a little bit slow. Should be loading.
That's all right. Thank you, Carolyn. Now, we know general practice plays a very important role in the healthcare system as the medical discipline within primary care. We provide patient-centred, continuing, comprehensive and coordinated whole person healthcare to individuals in the unique context of their families and communities. Now, each year, almost 9 out of 10 Australians visit general practice. This offers unparalleled access to the population, and there is consistent evidence that GPs can improve patient behaviours. Next slide, please. As GPs, we have responsibilities in whole person healthcare. This includes preventing chronic diseases, early detection through evidence-based screening, improving health and wellbeing, health education and promotion, including addressing disparities faced by priority populations. Now, you can see in this graph, 57% of GPs reported preventive activities in their 3 most common reasons for patient presentations in 2022. Next slide, please. Our role in prevention includes all measures aimed at improving health and maintaining wellbeing over the person's lifespan. We have primary prevention, which is aimed at preventing disease before it occurs. These include lifestyle advice, immunisations such as the HPV vaccine, education and promotion. There's also secondary prevention. Secondary prevention and screening is aimed at reducing the impact of the disease at an early stage before it occurs. These include the early detection of diseases and screening, which is the examination of asymptomatic people in order to classify them as either likely or unlikely to have a disease. Now, these include the cervical screening tests and screening mammograms. We also have a role in tertiary prevention, which is aimed at reducing the chronic impact of diseases after it occurs. These include work in chronic disease management for cancer survivors, for instance, the management of fatigue, anxiety, or the fear of recurrence after cancer diagnosis and treatment. Next slide, please. Now, this is a capture of the most recent edition of the Red Book, the 10th edition, which was released in June this year. It offers comprehensive and concise evidence-based recommendations with additional information on how to tailor recommendations, sometimes based on personal risk levels and patients' need. Now, it has some new sections on bladder cancer, lung cancer, pancreatic cancer and thyroid cancer there, as well as other systems, other chronic diseases using grade-like recommendation. Next slide, thank you. The Red Book offers recommendations for breast cancer, cervical cancer and colorectal cancer screening based on age. GPs have important responsibilities in each of the program. The cervical screening program invites women and people with a cervix who have ever had sexual contact between 25 to 74 years of age for HPV screening every 5 years. From July 2022, patients have the option of a clinician-collected sample or self-collected vaginal sample available through general practice. From July this year, people between the ages of 45 to 49 can also join the National Bowel Cancer Screening Program. So a couple of population based screening programs that we can support patients with. Next slide, please. The Red Book also offers recommendations for screening based on overall risk levels. And here in this slide is an example of a couple risk tools that are recommended in the Red Book for use to determine skin cancer risk levels based on multiple risk factors and overall skin cancer risk. These tools are available freely online, and the Red Book recommends opportunistic examination of the skin for those at above average risk. Regular skin checks around every 12 months for those at high risk. Regular skin checks every 6 months for those at very high risk, and we can use these calculators to provide an estimate of risk levels based on the patient's personalised risk factors. Next slide, please. Now, challenges and opportunities for prevention. There's enormous potential in general practice for prevention, and prevention is part of our comprehensive patient care. However, it's not always systematised and delivered routinely. There are time constraints in general practice, there's competing priorities, together with workforce shortages in general practice as well as in primary care. So the GP often needs to balance preventive activities with other care needs within the broader context of general practice, and we do undertake many preventive activities opportunistically. But there are ways to incorporate prevention into routine care. And there are opportunities, for instance, to integrate our software with the National Cancer Screening Register. And I've got a little video here on the link. Not sure if it'll work. I can hear it.
National Cervical Screening Program data. One of these ways is by connecting the register to clinical information systems, so you can access your patient's cervical and bowel cancer screening data directly through your existing desktop software. If your practice's clinical information system is integrated with the register, you can now access cancer screening data directly from your desktop. Once you are in the patient record within your system, you will be able to check patient screening information, program status, and download cervical screening histories. Receive notifications of overdue actions. Manage your patient's participation in the bowel and cervical screening programs. Order a free replacement bowel screening test kit directly to your patient's address. Create and send program forms, moving the need to print, scan, and fax to the register. And view patient program correspondence. The National Cancer Screening Register's clinical software integration helps you better support your patients by allowing you to access their bowel and cervical screening program related data at any time. For more information on the register, or to see which clinical information systems are currently integrated with the register, visit ncsr.gov.au.
Thank you. Thank you. This is an exciting opportunity to be able to support cancer screening in our patients. There's also opportunities for integrating and incorporating prevention into our health assessments and our chronic care planning using existing MBS item numbers. There's also opportunities for making use of other members of the general practice team, for instance, working with the practice receptionist or practice nurse to compile our own list and to actively recall patients. We can also work closer together with local allied healthcare providers to support prevention, whether it be primary, secondary, or tertiary prevention for our patients. So I think we can incorporate prevention into routine care based on local resources. And I'll share the next slide, which is the reference list. Happy to keep talking through the Q&A, and also like to take this opportunity now to introduce our next speaker, Associate Professor E. Associate Professor E is an academic GP and nationally recognised emerging leader in chronic disease management in primary care. Her program of work focuses on co-creating and evaluation models of cancer survivorship care that aim to improve and optimise patient outcomes and prioritise patient wellbeing. Within this, her research has a particular focus on the intersection between cardiometabolic and women's reproductive health and cancer survivorship, as well as on reducing health inequity and increasing access to care. Carolyn will be speaking about patient-centred and culturally safe cancer care across the cancer continuum. Thanks.
Thanks so much, Kylie. That was fantastic. And I apologise for not having my camera on. I've been struck by the windy weather and currently sitting in a blackout zone. So just bear with me as I hopefully make it through the next 15 minutes with this presentation. I'm going to start off with a rapid fire trip through Australia's migration history. So our Aboriginal and Torres Strait Islander community have been traditional custodians and owners of this land for over 50,000 years. Then the first fleet arrived in 1788 and Australia then became a colonial outpost. And the first fleet was then followed by waves of free settlers. And then there were migration booms during the gold rush and both world wars, and also quite a bit of humanitarian resettlement over the years. And today, Australia is a remarkably diverse country, so with almost 1/3 of Australians born overseas. So hopefully you can see the slide. Now it's a little bit slow to advance. You should be able to see the steady increase, of people born overseas since the middle of the last century. And more than 1 in 5 Australians speaks a language other than English at home. And currently there are more than 300 languages spoken in our country. But even though we are such a rich multicultural society, we have a largely monocultural healthcare system. So our system was built for Anglo-Australians who do speak English. And when it comes to cancer, it means that health information is generally inaccessible to the 1 in 5 who don't speak a language other than English at home. And even if information in language is provided, ironically, you often need to be able to read English to access kind of the portal into this important health information. So this can lead to a number of systemic barriers to accessing optimal cancer care, and this exacerbates the individual cultural barriers faced by our culturally and linguistically diverse Australians, or called Australians. And these barriers include, but they are not limited to, difficulty with communicating healthcare needs, a failure to accommodate health cultural practices in our healthcare settings, and low health literacy. But simply translating information into language isn't going to address these barriers. They are underlying cultural beliefs that can have a significant impact on how cold Australians can engage or may not engage with health information and services. So, in a number of cultures, a diagnosis of cancer will bring shame and is associated with secrecy and guilt. And cancer and death can be taboo subjects. And cancer might be seen as a sign of bad karma or God's punishment. So, a very different experience to our Anglo Australian culture, where friends and families bring lasagnas around and provide emotional and practical support. So, in our focus group research, we've been told of people not disclosing their diagnoses even to their partners for fear of being rejected. So particularly as in some cultures, cancers of female body parts, such as breast cancer, might be interpreted as a sign of infidelity. So our healthcare system can be confusing to navigate even if you're not culturally and linguistically diverse, but it's even harder to navigate for cold Australians with cancer, given it's often very different to the system at home, and information is complex and not provided in language. So all of these barriers can lead to lower participation in the population-based cancer screening programs that Kylie and Vivian previously described. They can lead to higher unmet needs and risk of depression in survivorship and a lower likelihood of accessing palliative care. So as Vivian pointed out, our Australian Cancer Plan has made achieving equity a key strategic objective. And in the plan, health equity is defined as an absence of disparities for people with different levels of social advantage. And achieving equity requires a response from health systems, not just individuals or providers. And the plan calls, as Vivian pointed out, for the provision of tailored, appropriate and adequately resourced services to all Australians in need, so according to when, where and how they need them. So let's look now at the impact of general practice on cancer outcomes. So this is a seminal paper by Barbara Starfield, and she reported that a higher number of primary care physicians, or PCPs, per capita is associated with lower all-cause and cancer mortality, and also is associated with an increase in lifespan after controlling for the usual socio-demographic measures that might otherwise explain this. So an increase of just one additional primary care physician per 10,000 of the population resulted in a 5% decrease in cancer mortality. So a strong and well-funded primary care system can mitigate or even get rid of the impact of income inequality. And having more primary care physicians per capita in low-income areas was shown to increase the chance of an early cancer diagnosis, which is due to an increased focus on prevention, screening, better quality of care, and provision of first contact care. And Kylie talked a lot about the role of GPs in cancer screening, and there is consistent evidence that GP endorsement of cancer screening is effective. And this might be an SMS from the practice, as in the Australian Smart Screen trial, which demonstrated a 16.5% absolute increase in bowel cancer screening rates with an SMS. It could be a letter from a GP, or it could just be a 2-minute recommendation during a consultation. So this was an email from one of my patients last week who booked in for her screening, and she was overdue. So for culturally and linguistically diverse Australians, GP endorsement appears to play an important role in raising awareness about screening and also taking part in screening, as per this qualitative study by my colleague Canis Kwok. So what about GPs and survivorship care? So a colleague, Julian Vos, also an academic GP based in the Netherlands, conducted this systematic review on primary care-led survivorship care. So this is distinct from shared care, which Michael Jefford will speak to later in the panel discussion. So Julian found that primary care-led survivorship care was as safe as secondary-led care. GPs were more likely to adhere to guidelines, and this model was preferred by patients and also more cost-effective overall. So GPs also play an important role in survivorship for CALD Australians. So these quotes are from a recent focus group led by my colleague Suzanne Grant, and this indicates that GPs do provide vital advice and information and provide comprehensive and coordinated care. Now, palliative and end-of-life care for CALD Australians can be complicated by different cultural beliefs about death and dying, and a lack of understanding by healthcare services about different cultural practices. But the existing relationship between patients and their GPs can be an enabler for the delivery of palliative care. And this paper by academic GP Lawrence Tan describes the role of bilingual GPs in survivorship care for CALD people. So you can see here this Vietnamese-speaking woman is clearly relying on her bilingual GP to navigate her to where she needed to go. And bilingual GPs and GPs from a similar cultural background appear to be trusted by patients. Now, the problem is that not every CALD Australian can easily access a bilingual GP, so someone else often needs to step in to be that navigator. So I'm going to talk now about patient navigation. So it's a term that's increasingly being used recently. So patient navigation is essentially any activity or role that reduces barriers to accessing optimal healthcare and that facilitates timely access to quality care. So anything that gets patients to where they need to go. So recent evidence on patient navigation in cancer care comes from these two reviews. So the first is an overview of reviews on patient navigation across the cancer care continuum led by Ray Chen. And this was not limited to CALD people with cancer. The second is a systematic review focusing on CALD people with cancer and on the post-screening phase led by my PhD candidate, Sandra Sonego. So patient navigation is a multi-component intervention. It might include care coordination, education and information provision, empowerment, emotional support, advocacy, peer support, language assistance, and importantly, logistics and financial assistance. So things like booking appointments and providing transport to appointments. So you can see here that a GP's role could indeed include many of these components. Now, patient navigators can come from a range of backgrounds, including nursing or allied health or social work, community health, or even be a layperson or peer navigator. So someone with lived experience who's trained to be a navigator. It's not exclusive to culturally and linguistically diverse populations. However, it is usually aimed at health inequities. And obviously, it is ideal if navigators are bilingual in the case of assisting people who speak a language other than English. So how effective is it? So the umbrella review by Ray Chan's team found strong evidence of effectiveness for cancer screening, diagnostic resolution, reducing hospital readmission, adherence to surveillance appointments, improved decision-making and treatment knowledge and survivorship, patient satisfaction and quality of life. However, there is very little evidence from Australia in the cancer setting. So Sandra Sonego reported similar findings in her systematic review on CALD populations, including reduced time to diagnosis, reduced time to treatment, reduced missed appointments, fewer treatment interruptions, lower anxiety levels, and increased patient satisfaction. But you will note here that all studies were conducted in the USA, so there's a clear gap in Australian evidence. So to address this gap, I'm very privileged to be leading a team of amazing researchers on Australia's first trial of a patient navigation program for CALD people with cancer. We'll be delivering a co-designed patient navigation program based on a model incorporating peer navigation and offering education, logistics support, peer support, empowerment and supportive care to Chinese and Vietnamese speaking people with cancer. So I'm going to end now with just a few suggestions about how to provide person-centred care for CALD Australians with or at risk of cancer. Now, these are not comprehensive. They are not one size fits all. They are just some things that GPs can think about. So the first seems really obvious, but be respectful. So it's astounding how many people are treated really badly, even with contempt, just because they can't understand the language that you are speaking to them. So it's important to build trust, especially as there might be fear of health services or a history of trauma. Think about the role of gender within the doctor-patient relationship. So, for example, female patients may very much prefer to see a GP who identifies as a woman. Using interpreters is important, but it's not everything. Appreciate that for many cultures, it is a collectivist view. So it's the family unit that makes the decision and not necessarily the individual patient. And individuals are quite likely to be thinking about the impact of their family. So, for example, the financial and practical burden of what you're suggesting to them. GPs can play a really important role in addressing myths and incorrect beliefs about cancer. So, for example, explaining that cancer is not contagious. And when communicating with CALD patients about cancer, it can be helpful to focus on achieving health and well-being and not on the cancer itself, because some CALD patients with cancer are very uncomfortable if you actually say the word cancer. Providing information in language is important, and I'd urge everyone, so all GPs and primary care teams, to know where to go for multilingual information. And from our focus group research, we know that CALD cancer survivors are desperate for information in language about what to eat, what physical activity to do, and generally how to stay well. And last, it's important that you allow enough time in consultations for interpretation and for patients to ask questions. Thank you very much. I'm going to hand back to Catherine.
Wonderful. Thank you so much. Absolutely outstanding presentations. And I learned something new even from a GP lens listening to all our expert speakers. So thank you so much, Vivian, Kylie and Carolyn. And so I'm absolutely thrilled to be introducing 3 more important panel members to our seminar this evening, who will be answering questions during our panel session, but also in our Q&A. So please do keep your questions coming in, because we will have an opportunity at the end to address them. So first and foremost, it gives me great pleasure and honour to introduce Eric Young, who is the president of Can Revive, which is a public benevolent institution that helps minimise the impact of cancer on patients, carers and their families. It was established back in 1995, and Can Revive provides information and emotional support to cater for the cultural and linguistically needs of Chinese-speaking community in Sydney. Eric has been a primary carer of his wife, who succumbed to lung cancer, and to a brother-in-law who was lost by melanoma. Sorry, Eric. I would also like to introduce you to Associate Professor Joel Ree, who is the Chair of Cancer and Palliative Care Specific Interest Group, who is a GP with a special interest in primary palliative care and is the co-chair of Living With and Beyond Cancer Engine Room, PC4, and also who is the Head of Discipline of General Practice at UNSW. And last but not least, of course, Professor Michael Jeffard, who is a consultant medical oncologist at Peter MacCallum Cancer Centre in Melbourne, and who's also the director of the Australian Cancer Survivorship Centre. Most of his research has a particular focus on cancer survivorship, aiming to address the profound unmet needs of people, and in particular addressing the important areas of survivors, to develop and implement strategies to minimise post-treatment consequences, to develop improved models of care, and to better understand and minimise disparities in cancer survivorship outcomes. So such a warm welcome to everyone. What a rich and diverse panel that we have this evening. So I'm maybe going to start off and kick us off into our panel discussion here this evening. And first and foremost, of course, I would like to come to our most important panel member, and that, of course, is coming to Eric. So I'd like to start, first of all, by asking you, Eric, if you could tell us a little bit about what are some of the challenges that our culturally and linguistically diverse community experience at each stage of the cancer care continuum. So I don't know if you can touch a little bit on whether that be screening, survivorship and palliative care. Thank you, Eric.
Oh, good evening. Well, diversity produces many challenges as reflected in Kenry supporting of cancer-speaking people affected by cancer. We come to realize that cultural and linguistic differences between, well, you talk about Chinese cancer patients. Actually, there are 56 different races in the Chinese community. And well, those from China, Hong Kong, Taiwan, and any other part of Asia are very different. It boils down to the differences in needs and want to each group that affected the two more important aspects of communication and trust that influence the patient's and their family's decision-making process at each stage of the cancer continuum. Especially for the elderly and the newer migrant, they're trying to navigate through Australia's healthcare system, which in many cases is very different from the healthcare system where they originated from. And another challenge is that our system focuses on person-centered patient experience and outcome, but decision-making affecting the outcome of many cancer cow community is collective decision of the family, and in many cases, there's a surrogate decision maker for the patients, and every one of that affect each and every part of the center continuum.
Wonderful. Thank you, Eric. And just maybe expanding on that a little bit, because it seems, of course, there's so many profound challenges that many can experience. And just drawing upon your own experience, Eric, from your own perspective, what do you feel that the role of the GP is in addressing some of these challenges of what you've mentioned?
Well, I'm old school. I still call my GP family doctor. GPs, especially those that can speak the same language, play an important role in addressing the two aspects of communication and trust. At Kenry, we always advise our cancer patients and the family that the patient is looked after by a team of medical professionals, not just the medical oncologists or radiation oncologists, but including nurses and other support care personnel. And also in that team are the GPs. Well, we always advise our patients not to go GP shopping because it's better for a GP to have a more complete picture of their health history, including any chronic illness, that can better communicate with the team. Now, being familiar with the GP build trust and other factors that come into it, I call the 4 A's: acceptable, available, accessible, and affordable. Now, a patient and the family can go and see a GP, at different time when they choose, but seeing an oncologist is pretty difficult and expensive. Cow patients are more likely to discuss openly with their GP and claim up when they see their specialist, especially when there is the need of an interpreter. So the GP plays a very important role in bridging the gap in communication and building trust, which affect the decision of the patients.
So good. Thank you so much, Eric. And maybe just the last question that I think will be of benefit to our audience and particularly for our GPs. who may not know about the wonderful leadership work of what you're providing for Can Revive. And I'm just wondering if you could maybe touch on an example perhaps of how Can Revive can help meet some of the needs of these patient groups that you've mentioned, Eric.
Yeah, well, Can Revive actually, well, in the last 30 years, we've been having support group, well, that start from the very beginning of diagnosis of cancer, which is a program they run in partnership with local health district with various hospitals called Living with Cancer Program. Basically, it targets newly diagnosed patients and their family with the most up-to-date and correct information. Now, this is delivered in partnership with various hospitals, and it covers everything from treatments, side effects, nutrition, and even the psychological part of things. And in our support groups, we split them up into newly diagnosed. Those are between 2 to 5 years, which is we call the survival group, the survivor group. And well, one other group that after that we call the happy group, those who survive cancer and they still stick around, want to be part of the organizations. And we also have a very palliative care group that look after those kind of transition to the end of life stage. And finally, there is a group that we call the bereavement group. We support the family for someone passed away with cancer for over 2 years. The palliative care group kind of help us to transition the people, the primary carers in the family into the bereavement stage of their cancer journey. Even though they don't have cancer, they have gone through a cancer journey. We do, Can Revive, like some other support group in the community, we do a lot of things called interest group. They are actually therapeutic group like your Tai Chi, your Qigong, your yoga, and the mindfulness classes and everything. We call them classes because our patients told us not to use the word therapy. So they have classes, interest group classes, workshop, rather than therapies. The important thing about this group is peer support and social connection. For cancer patients to feel isolated is the worst case, because that's why Can Revive's mission is that no one should face cancer alone. Social connections and peer support brings out a lot between cancer patients, because invariably, patients among their peers, especially those with the same kind of cancer, opens up and discuss about things that is worrying to them, important to them. And our facilitator and volunteer invariably would be advising patients to go talk to the doctor, talk to the GP, ask the GP to teach them what to ask the oncologist, because a lot of cancer patients in the CAL community are either too embarrassed, too afraid, and don't know what question to ask or express what is happening to them. And through all these groups and all these peer support meetings, we encourage patients to connect with their medical professional, their team of doctors, their team of medical professionals, that invariably include the GPs.
Yeah. Wonderful. Thank you so much, Eric. And it's very clear that having that partnership and support is making a tremendous impact on the lives of people affected by cancer. And so that brings me into a nice segue to maybe perhaps come to you next, Michael, if that's okay, in thinking about partnership, shared models of care. And so I'm wondering, Michael, just with your expertise and your hugely successful clinical academic track in survivorship care, can you tell us a little bit about what is shared care and what does the evidence say about shared care models in cancer care, please, Michael?
Yeah, thanks, Catherine. So following on from Carolyn's comment about the effectiveness of GP-led care, So shared care is really a formalised arrangement in which follow-up is shared between patient's GP and their oncologist. I mean, shared care can be used in different circumstances, but I think that's what we're really talking about now. And so it's basically just agreeing on shared roles and responsibilities. And we hope in shared care that it's the best of good quality generalist care and good quality cancer follow-up. And there's been a number of studies of shared care, including in Australia. I've been quite involved with a couple of studies, particularly follow-up for men who have been treated for early stage prostate cancer, and also for people who have been treated for early stage colorectal cancer. And both of those studies had very similar findings. They both found that shared care produces similar quality of life results as for people in shared care as hospital-based care. GPs do a better job of doing the tests that are recommended in terms of if we're suggesting that people have regular CEA blood tests or a regular PSA test, they do a better job than the hospital providers. Patients prefer shared care compared to hospital-based follow-up. And also shared care is cheaper to the healthcare system compared to hospital-based follow-up. So our conclusion is that we should be doing a lot more shared care in Australia.
Yeah, very good, Michael. And I'm just wondering, just because obviously our healthcare system, it's a truly wonderful healthcare system, and we heard we have some of the best cancer outcomes for all patient groups. But it can be a little bit tricky, as we've heard, in relation to the importance of navigation. And just thinking about what are the challenges? So what were some of the implementation challenges that were found when it came to implementing shared care with general practice, Michael?
Yeah, so this is not straightforward, and it doesn't happen just because you want it to happen. And I should say too, that Cancer Australia have produced good guidance around shared care and recommend shared care as a standard option for people who've been treated for early stage breast cancer and endometrial cancer as well. So this is not just specific to prostate and colorectal cancer, but back to your question, it does require quite a bit of setup. And in particular, I think that it probably goes without saying, and I think that everyone on the call would empathise with that. We need to make sure that this is well planned with general practice. We need to set things up well. We also need to prepare both patients and the whole different providers, GPs, oncologists. We need to prepare people early. We need to make sure they have the right information. We need to make sure that there's good communication, that we're very clear about who's going to be doing what, so roles and responsibilities. We need to make sure that patients are told about the evidence to support shared care so that they understand that and that they also feel well prepared. We also need to make sure that GPs are given the information they need. So they need information about the person's cancer diagnosis, their treatment, what to be looking out for, and they also need to be given some guidance. And so, and that guidance might be, can we recommend that you do a history and examination and this blood test, CEA, PSA, this frequently? And so we just need to be able to provide that guidance very clearly. We also need to make sure that GPs have easy access if they're not sure or if they have concerns. So if they have concerns about potentially somebody who might have cancer recurrence or other concerns, then they need an easy way to get someone back into the healthcare system. So lots of planning. And I think also we have to acknowledge too that we need the right policy and funding environment to support shared care. Because, if we have a universal system that makes shared care work, that will just make it a lot easier. At the moment, that it can work, but we all recognise that there can be challenges, and so I think that we probably have some way to go in terms of getting that just right.
Yeah, so good. Thank you, Michael. And so not only did you identify some of the challenges, but you provided some really good practical insights into how to overcome some of these challenges for our GP community who might be thinking about setting up shared care. So we obviously, all of us know that we're on the call tonight, that we know that it takes a village to deliver excellence in cancer care. And so I would just like to circle back a little bit more around the practicalities and the implications for other allied health and nursing professionals who might be involved in shared care. And so I'll maybe open that up to Carolyn and you, Michael. So thinking about how best do we deliver multidisciplinary or indeed interprofessional, which is really the gold standard, cancer care that's really leveraging the full multidisciplinary team to ensure that we are getting it right at every time for each person at each point in the cancer care continuum. So just circling back to the practicalities involving allied health and nursing within that shared model of care as well. So to you, Michael and Carolyn, if that's okay.
Yeah, it's 100% that a lot of survivorship care probably doesn't necessarily even need to be medically led, and there are good examples of nurse-led follow-up, and they could also be nurses based in primary care. And a lot of the surveillance recommendations certainly could be within scope of primary care nurses, and also a lot of the advice around survivorship care around diet, exercise, smoking, alcohol, the need for tertiary screening, as Kylie talked about. Again, that would all fit within primary care. And I would hope that the multidisciplinary team in the community would be providing a lot of survivorship care, and increasingly, perhaps the majority of survivorship care going forward. The other thing is that patients often want care closer to home, and the GP is the right person to be coordinating that and potentially referring to necessary allied health in the community, whether that's psychology, dietitian, exercise physiologist, and the GP is the gateway and the coordinator of that. But I'll hand on to Carolyn and let her give us her thoughts too.
Thanks so much, Michael. I think you've put it beautifully. GPs are the care coordinators. It's our bread and butter. It's what we do all the time. We are fantastic at managing multi-morbidity. So we deal with the person and not just a diagnosis. So we certainly do bring a lot of value to this. I would say that there are some challenges that are faced with providing, the optimal multidisciplinary care to our patients. So obviously access can be challenging depending on possibly where you live, if you're rural and remote, or the out-of-pocket cost that comes with accessing multidisciplinary services can be really challenging as well. And then with something like cancer, I do find that it's very helpful to have allied health professionals who've got some expertise and interest in managing cancer survivorship. And again, I think this is an incredible field, and it's growing rapidly, but sometimes can be a little bit tricky, to find the right healthcare professional. But absolutely, I think multidisciplinary care and primary care teams in particular delivering care in the community is absolutely vital in survivorship.
Yeah, wonderful. Thank you so much, Carolyn and Michael. And we have spoken a lot about, I think, survivorship, and importantly, Eric did touch in relation to the support required for people affected by cancer who are requiring palliative care and end-of-life care affected by cancer. And so I'd really like to come to our expert, Joel, in this space, if that's okay. And if I can just ask you, Joel, what is the role of GP in these stages in thinking about people affected by cancer at end of life and palliative care? If you could maybe share your insights there.
Yeah, thanks very much. Yeah, so clearly the GP has a very important role, and I think probably something that will probably start off with is looking at palliative care as an approach to care. And I think that's a really important concept because often when we use palliative care, the term, we often use it to mean the service, the specialist service. So we say refer to palliative care as in meaning we refer to palliative care specialist service. But palliative care is actually an approach, and that's important because GPs, primary care providers, other non-GP specialists, nurses, allied health, we all have an important role to play in that palliative approach to care. Some patients may require palliative care specialist involvement, but clearly in some settings like rural and regional settings, that's even by geographical reasons, that's limited. And even in metro settings, it's probably not going to be possible for specialist palliative care service to provide palliative care to every single person who dies in the community, because so far everybody dies, and there's just not enough specialist palliative care service providers to do that. So the partnership between general practice and specialist palliative care service is really critical. And so in terms of what GPs do, it really depends on the setting and the interest and the confidence of the GP, but it can vary anywhere from mainly being the support sort of day-to-day person who provides that care to patients, and rely on the specialist palliative care to do the regular reviews and provide any advice on changes in management. So that can be one level. But others who are a bit more confident can actually do a lot of the management and changing medications and other things by themselves, with a bit of support from specialist palliative care. And obviously there are opportunities for GPs to upskill, and there are several programs which are in existence where GPs can do anything from a week of experience in specialist palliative care units to doing a diploma course, or even and some people would choose to sort of undertake 3 years of specialist training. So there are different levels, I think, where primary care can provide that end of life and palliative care to patients.
Wonderful. Thank you so much, Joel. And then maybe coming round to Vivian, in relation to the current national review of the breast screen programme. So I just want to make sure that we're touching on all the important elements here. So coming round to you now, Viv, if that's okay. So what are some of the potential challenges that GPs and primary care teams need to be aware of in light of this?
So thanks, Catherine. It's a really important point. Both Carolyn E. and myself, we sit on the expert advisory group that's overseeing the new or the breast screen review. So we know that we have a breast screen program that is based on doing a mammogram for every woman aged 50 to 74, but actually eligible from the age of 40, but targeted from 50 to 74. Every woman has a mammogram every 2 years. And we know that that happens regardless of their individual risk. And it's been a fantastic program, but it's time for review, and it's time for us to be thinking about what actually could we do to maximise the benefit and minimise the harms of breast screen. So we've done it's a very large review that's based on an evidence review, a data collection, looking at the views of people involved in breast screen, both people who work in breast screen as well as community members and consumers with breast cancer, looking at the funding models, and actually going at it really sort of laying it all open and thinking, what can we do to make a difference? We are considering whether there should be a change of age. We're considering whether there should be a change of screening pathway for people with different risk factors. We're considering whether we should have a different screening technologies. But we're also looking at participation. Across the board, breast screen participation is only around 55%, a little bit more in some areas, a bit less in others. We know that there are some populations who screen less. We have lower participation for Aboriginal and Torres Strait Islander people. We have lower participation for those in rural and remote areas, and for some particular communities. So we really need to be thinking, how can we get better participation across the board, particularly for priority populations? So basically, we're in the middle of that review. There are no answers yet, except to say that I think over time, the idea of risk stratified screening is one of those things that just will happen. We need to be actually thinking, for some people, do they need a more intensive or a different screening process, potentially with different technology? And that might be those people who have increased breast density. It might be people who have family history or past history of breast cancer. But basically what will happen at the end of this review is we'll have a number of recommendations. Some of those will be in the short term, some of those will be in the medium term, and some of those will be part of a 10-year strategic plan. So watch this space. There's really nothing to share at this stage, except to say that it's a national, it's an amazing national resource that we have in BreastScreen, and we really want it to make it work best for all women in Australia.
Yeah, amazing. So good, Viv. And just a last question that I think will be really, really important for our GP audience as well, which you did touch on, is how do we increase full participation, so full reach and participation in screening for people with cancer. So what would be some of the other innovative ways to increase cancer screening that have been piloted and implemented? I don't know if you perhaps want to touch on the Menzies pilot, perhaps, Viv.
Yeah, so some people might know already about the alternative access scheme for bowel cancer screening. So one of the things we knew a few years ago was that there was a much lower participation in bowel cancer screening for Aboriginal and Torres Strait Islander people. And when we looked at that, some of that was because of the way that bowel cancer screening is delivered to people. So it comes in the mail in a letter with a government crest on it. It comes by post. And actually talking to Aboriginal and Torres Strait Islander people, there was a lot of hesitation to engage in a system that was delivered like that. So the Department of Health and Aged Care, Commonwealth Department, engaged Gail Garvey's group Gail was then at the Menzies Centre for Health for Menzies in the Northern Territory, and Gail conducted this co-designed approach to changing the way that Aboriginal and Torres Strait Islander people engage with the program. And it was tremendously successful. And she did it with actually talking to communities. They made resources for communities that were not just written. There was visual, there was song-based, there was all sorts of ways of engaging with the community. But the main thing that changed was the way that people access their kit, their bowel cancer kit. So instead of getting it in the mail, they got it from their trusted Aboriginal medical service at that time. So the person that they trusted, their GP and the rest of their healthcare team in the Aboriginal medical service, was able to hand out the kit. And one of the things that actually really came from that is that we realized that the voice of the GP is tremendously important in encouraging someone to participate in screening. And now there is an opportunity for GPs to order kits for their patients. And Kylie talked a bit about the interaction with the National Cancer Screening Register. If you log on to the National Cancer Screening Register with your patient there, you can order a kit for them to come straight to their house. So rather than just sort of say, bowel cancer screening is a good idea, and the person thinking, well, actually, I got it in the mail last week, but actually I threw it out, and having to wait for the next time, the GP can actually engage with the register and help the person access their kit. And actually that's making a big difference. The other thing to say just before we leave bowel cancer screening is that everybody may not know that the age of screening has reduced now down to 45. So we have had a program that's been 50 from the age of 50. A few months ago, it actually reduced to 45. It's an opt-in program, so that a person is not going to just get something in the mail from the age of 45. They will still keep getting kits in the mail from the age of 50, but from the age of 45, it's opt-in and they can do that together with their GP.
Wonderful. Thank you so much, Viv. Now, I'm conscious of time, that I'm trying to keep us best to time, and I just want to make sure that we get the opportunity to answer these questions that people have kindly posted. So I'm just working back from time-wise, and this is a great question here, and this probably will come to you again, Vivian, if that's okay. So is age requirement for the lung cancer screening the same or different between Aboriginal and non-Aboriginal Torres Strait Islander populations, please?
Yeah, great question. And I will keep my answers short because we want to fit in as many as possible. Yes, it's the same, 50 to 70-year-old for both Aboriginal and Torres Strait Islander people and non-Indigenous people in Australia.
Wonderful. This is like rapid fire now. So sorry, Michael, I'm coming to you, if that's okay, just in relation to clinical trials. So this from Narelle. So what role does primary healthcare play in raising awareness of cancer clinical trials as a treatment option? Michael, to you.
I probably should go to a GP really, but I guess I would say, the treatments that we have now, are based on clinical trials. And, if we look at, say, immunotherapy has completely revolutionized cancer care over the last decade. And that's from clinical trials that were conducted only in the last few years or so. So we do need to support ongoing clinical research. We have a really great research community in Australia, but most people will be given information about a trial and then they'll be told to go away and think about it, go and chat to your GP about it. And often GPs know patients well, and they might be able to help them with decision making, help them with thinking about their own values, their own perspective, perhaps other illnesses, help answer some questions. But I think that it's really important for GPs to try and support clinical research and to be a trusted source for their patients.
Perfect. Thank you, Michael. And just touching round, I think also from the GP lens, sorry, that was a generic question here, Michael, around clinical trials, but circling round to anyone within our expert panel around perhaps the GP role, I think was the second subpart to that question. What role does the GP have in supporting clinical trials?
If I could just jump in, Catherine, I guess as a GP, I totally agree with Michael. He's got an important role, but I think one of the challenge that GPs face is the fact that they're not supported. So GPs are not supported in supporting people for clinical trials. So this is a big issue. So often if GPs are sort of helping to recruit patients for trials, then obviously all of that would cost a lot of resources. And the other, I guess the other thing is sometimes if the patients are coming back from various tertiary centres with information about trials, and then GPs are sort of looking through that, then there's not a lot of support for the GPs to be involved in that. And from the GP perspective, it's not something that they it's not something that was generated from their own sort of organization. It's coming from a different hospital or different place. So I think if there's a way to communicate better with GPs about these trials and provides extra support for GPs, I think that'll be really useful. Thank you.
Thank you. And perhaps just the last question that I can see in the Q&A is from Katrina. And perhaps I'll maybe direct this to Eric or anyone else in the panel. Do CLAD patients feel better with their interpreter in person or on the phone? Are they more likely to open up to the interpreter is on the phone? So I'm just want to make sure that we're coming back to a person-centered question, and so I'll open that up to anybody in the panel. But my first thought was Eric.
I'm happy to say something quickly too.
Yeah, well, I just came from a workshop with Macquarie University, specifically about the relationship between oncologists and the interpreters and patients. One of the problems that our experience is that the patients do not get the same interpreter every time. So the patients feel that they are having to explain themselves to someone who's totally foreign to them. Well, it's a total strangers, and well, talking about the cancer issues are a very personal thing, and there a lot of time patients are reluctant to be talking to an interpreter and not knowing what the interpreter is telling the doctor. So I raised the question with this group. Well, is there a possibility that the interpreter service can kind of narrow it down to one cancer patient while getting one or two interpreter all the time, rather than a different person every single time? And I believe there's a fair degree of difficulties in it because of the structure. So, and also we raised the issue whether it's well, better to be face to face than over the phone, or and kind of agree that face to face is important, because technically we're saying that the interpreters should be able to read some of the body language of the patients and the family, especially when in a cow community, you're not just talking to the patient, you're also talking to the primary caregivers and the rest of the family who make decisions.
Yeah, wonderful. Now, I know, Michael, we are coming short for time. If you've got time, are you okay? Okay. Are you sure? It might be something really important. All righty. Well, listen, I do better bring us to a close. And what a wonderful evening of such experts around the virtual table tonight. And so I'd just like to provide a summary of the key points from our expert speakers. And I wonder whether I might just, for a brief summary of the key messages, if I can just come to you, Viv, just for what are the key take home, just in a short snap bite.
Okay, I can't stress highly enough the importance of the GP and cancer screening in recruitment, in support of your patient's participation, and in understanding how important it is that we diagnose cancer at an early stage. And look out for the lung cancer screening program. There's a lot of information online, and it will be coming to you, I think, from all directions between now and the end of June for the new program from July. Thanks.
So good. Such a blessing. Thank you. And to Kylie?
Thanks. My key message: prevention, including cancer prevention, is part of comprehensive patient-centred care.
Wonderful. And Carolyn, I hope we've not lost you with your power outage.
Oh, I'm still here. My key message is that a strong and well-funded primary care system it improves cancer outcomes, and GPs play a really important role in reducing disparities in cancer outcomes. Thank
Wonderful.
you.
Thank you. Well, listen, I just want to thank everybody for taking the time and care to link into such a wonderfully rich session this evening. I would also like to thank Cancer Australia and PC4 for partnering with us at Flinders University, our Cancer Survivorship Programme, and of course to all of our wonderful, amazing panel members and presenters for linking in with us this evening. So just the last thing to say is that, of course, we will be sending out an evaluation survey after tonight, as well as the recording of this session, that when it will be ready and available for you. Just as the last thing, in thinking about your continual professional development, please do email us. It's not a problem at all. If you didn't provide us with your CPD number at registration, just send that through to us along with your name, and we will sort that out for you. So again, sincere thanks for such a rich and wonderful session this evening. Thank you.